Okay, I'll grab your attention as we're going to kick off with our afternoon presentations. So, for those of you who may not know me, my name is Julia, and I'm one of the project officers here at VADA. I've been supporting the planning of these nurses forums since their inception about 4 years ago. And I've really grown to love planning these, as it's a really good space where, all of you guys get together and we get to dig into some really clinically focused topics. So I'm really excited to introduce our next presenter, who's Dr. Zeff Koutsogiannis, sorry. And he is a senior clinical toxicologist and emergency physician at the emergency department in Victorian Poisons Information Center at the Austin Hospital. Zeff has an interest in illicit drug use and dependence, critically ill poisoned patients, acid-based disturbances, and management of pain. He'll be joining us today to present on his presentation, When You Get Bumped and Trip into the K-Hole, which I think deserves a bit of an award for the most creative title I've seen in a while. And also noting that, this ketamine topic, it's a really interesting one, and one that's kind of at the forefront of discussions right now, noting that the latest wastewater monitoring from the ACIC in April to June of 2023 noted that ketamine use has hit its record peak in Australia. So it's definitely a substance that we're seeing more predominantly. We're seeing consumption increase. And I'd say we're seeing it in the narrative of psychedelic therapies and other things. So with that, I'll hand over to Zeff to give us a full toxicology of ketamine.
Thanks for that introduction and inviting me to speak here today. I feel like a bit of fish out of water because you guys are sort of out there doing the work, and I'm on the inside in the emergency department and poison center seeing a different aspect of it. So I've had a professional relationship with ketamine for over 20 years, seeing it both in the emergency department, with me actually giving it to people, but also seeing it from a toxicology and poison center point of view. So I'm just going to do a brief overview of ketamine through my lens, and I'm here to actually learn from you guys, because you will see a different aspect of ketamine. So I'm hoping that some of this stuff some of the stuff you'll know. So I'm sorry that if I'm telling you how to suck eggs, but some of it you may not know. So we'll just go through it. And ketamine is quite a versatile drug. It's used for lots of things, anesthesia all the way to curing suicidal ideation and depression and everything in between. I love it. I think it's a fantastic drug in many ways. If I had to pick my top 10 deserted island drugs, ketamine will be in the top 10 because it's very useful for lots of things. But having said that, is it working? Okay. It's not for everyone, and I've known that from my experience in giving it to people when I've gone, maybe I shouldn't have given you the ketamine. So a bit of history. I don't know whether Park Davis is a drug company which is now owned by Pfizer, but back in the day, 1956, they synthesized PCP, or phencyclidine, or angel dust as it's known on the streets, as a general anesthetic that was good for, it didn't depress your breathing as much, and therefore is much safer anesthetic to give, and you can give it intramuscularly. The problem with PCP was it caused vivid dreams and confusions and emergence coming out of the anesthesia. It was quite horrible for people, and they didn't like it at all. So they thought, oh, well, maybe we've sort of a bit overcooked that style of drug. So hence they've synthesized ketamine, which seemed to be a much gentler version of it, and seemed to be a better fit for the purpose of the drug company using it as an anesthetic. And in 1964, controversially, it was experimented on prisoners. No ethics committees back then. And it was given to a human for the first time before there was animal studies in 1964. And one of the doctors, Dr. Edward Domino, I think his name was, he wanted to market it as a dreaming anesthetic. And his wife, and the Park Davis said, no, we don't like that. And his wife said, actually, people, when you give ketamine to people, they just look like the lights are on, but no one's home. It's as if like they're dissociated from the world. So that's where the term, it's a dissociative anesthetic, comes from, because you're sort of dissociated from, your body's dissociated from your mind, and your pain is dissociated. So then it's approved by the FDA in 1970. So, and then it started being used in places where you think it's pretty hard to get a drip in people. I need something that I can give intramuscularly that can knock people down and use an anesthetic. So battlefield, and used in Vietnam. And that's where it sort of started, which is a fantastic drug for that. In fact, ketamine is the most widely used anesthetic in worldwide, you know, in the third world and so forth, because of the IM aspect of it. It's used in vet medicine and uncooperative children, which I use it at home for that. No, uncooperative children is, imagine trying to anesthetize a 3-year-old just having, you know, grommets or something, and you can't get near them. So ketamine was good for that sort of thing. So gets approved in 1970, and then surprise, surprise, from 1971 onwards, it started being used in recreational circles. And a lot of it is experience from health professionals, because they procured it from their clinics, but also from Vietnam vets who came back from Vietnam and said, I was given ketamine in Vietnam, and it was amazing. So the Mind Explorer Psychonaut people started using it. It was used as a liquid in 1971, started using powders and pills in 1974. And then by the 80s, it sort of morphed into in the States anyway, the West Coast of the States, California, mainly into the dance, rave, you know, electronic music culture. And that slowly moved on to UK and Europe in the 90s, and in Australia, but it didn't hit sort of its straps in Australia to 2000. And that's where sort of it's come from. And in Hong Kong, some places like Hong Kong, it was the most widely used recreational. Everyone was using ecstasy and all the NPSs, and Hong Kong was just using ketamine in the late 2008, 2010 sort of period. So, you know, so it's gaining popularity. It's got street names, as you know. There's lots of them out there. These are just some of them. Special K is probably K, Special K. Cat Valium. I think there's all these animal references because of the vet medicine aspect of it, and horse trank, because, you know, horses are large, and to knock down a horse or a large animal. Having said that, horse trank, that's not true. So if you want to try it, it doesn't work like that. So looking at our drug wheel, there's different groups of drugs that people use for recreational use, and ketamine falls under the dissociative group, I guess, from the term that we just mentioned historically. And other drugs in that group are methamphetamine and nitrous. So nitrous gives you that dissociation effect, but not as prolonged, sort of the short-acting thing. Ketamine, we'll talk about it in a minute, causes hallucinations. People call it a psychedelic. It's not a psychedelic. I guess it's semantics, but psychedelics are serotonin agonist type drugs that cause psychedelic effects. So, you know, we're talking magic mushrooms and LSD and DMT and those sort of things are psychedelic. So even though ketamine can make you hallucinate, it's not actually a psychedelic. But chemical structures, if you're into them, it falls in the aryl cyclohexamine group, which probably means nothing to you, and that's okay. It just means that those two rings on the left-hand side is the base structure, and everything that sort of fits on top of that gives you a slightly different thing. I'm not going to talk about methamphetamine, and I'm not going to talk about PCP today. I'm just talking about ketamine, but they've got similar effects. It's just that their duration of action and onset of action and intensity is different. So if you're into merch, rather than getting the t-shirt, maybe a bit of jewelry. Christmas is coming, so perhaps a bit of a ketamine pendant. Now, how does it work? It's interesting. It's so the glutamate is a neurotransmitter that's sort of all over our body. It's in fact one of the most common ones. It's an excitatory neurotransmitter, and that runs through the NMDA receptor. And that's got implications in pain, in mood, learning, memory, those sorts of things. And ketamine blocks blocks that receptor. And because it blocks that receptor, it blocks all the excitatory neurotransmitter effects of glutamate. So therefore you can see how it would stop pain, it would stop mood, it would stop learning and memory and stuff. In addition, it also inhibits the reuptake of noradrenaline, dopamine, and serotonin, the three main neurotransmitters that a lot of people use with recreational drugs like MDMA, for example, or methamphetamine. And it can activate opioid receptors, which is probably also how it's used in pain circles, but not to the point where naloxone or Narcan, naloxone helps. So if someone's unconscious from ketamine, you can't give them naloxone and wake them up, because it's the ketamine unconsciousness effect is an NMDA effect, not the mu opioid receptor effect. So I use it a lot at work. It's used as an anesthetic. We've been using it increasingly more over the last 10 years, 10, 15 years for procedural sedation. So if you come in with your fractured wrist or dislocated whatever, then we can give you ketamine and as a procedural sedation and do what we like. Analgesic, so in small doses, it's a good analgesic, and we use it for people that are in acute pain, not as a first off, although we could, because opioids opioids are very effective. So people who are opioid dependent or opioids are not working, ketamine in low doses as an analgesic is a great alternative. It's gained popularity recently, say the last 5 years, as in acute behavioural disturbance, agitated patients who come in who need pharmacological soothing to calm them down. And ketamine, even though I love ketamine and I use it for lots of things, I've never used it for that purpose, because I think with verbal de-escalation and other medications, you can do that, whereas a lot of people may not have the skills to do that, so they tend to just go for ketamine. And ambulances have got ketamine now, so we get a lot of people that are coming on after being ketamined. But it's a knockdown drug, so if you're going to use ketamine for this purpose, you want somebody to be sort of knocked down in 5 minutes. Like they must be, like 300 kilos and on meth going absolutely crazy and going to kill everybody. Those sort of people that are disturbed like that. Whereas most people are agitated, you can sort of get away with that using ketamine. Asthma, it bronchodilates. So sometimes when people need to be intubated for asthma, ketamine's good for that. Chronic pain, so not in acute pain, but chronic pain, it sort of resets sort of your receptors, and people go into chronic pain admissions or private clinics and have a ketamine infusion for a week in low doses for their chronic pain. It can be used in seizures, and more recently it's getting more popular and approved, I think, and there's clinics coming up, and we'll probably be seeing more and more of this. And because we'll be seeing more and more of this, we'll be seeing more and more diversion, probably, perhaps, I don't know, for depression and PTSD and so forth. In fact, LSD and MDMA are also being used for these purposes as well, but ketamine is starting to be used. So these are medical uses. That's just to say that everyone just needs ketamine. I particularly like the last line, which says, "The patient's still in the waiting room?" Yes, ketamine. But it just feels like everyone's sort of getting it. So doing surveys of people who use illicit drugs, 3% have used ketamine at least once in their life, and almost 1% in the last 12 months. And that's getting more and more and more prevalent. And the average age is about 20 when you first try it. Comes in a powder or a liquid. It's usually a powder because people, and we'll talk about how people take it, the liquid's usually for parenteral use or intramuscular intravenous use, but most people use it as a powder. So it's an interesting drug because most drugs, when you give them a dose, they get an effect, and you give them more of a dose, they get more of that effect, and then more of a dose and more of that effect. Whereas ketamine is a bit like that, but it's also, you give them a dose and you have one effect, and you give them a bigger dose and they have a different effect, and then you give them a bigger dose and you get an even different effect. So it's not only is it more of the same, but it's different as you go along. So it's like the ketamine brain continuum. So small doses, where I use it at work in terms of analgesia, is analgesic dose. And then at the other end of the spectrum, the dissociated dose, that's the full anesthetic dose where you're not aware, you're unconscious. I mean, you're awake, you're not really awake because your eyes are open, but you're actually unconscious and not aware of anything. That's a dissociated, that's the anesthetic dose. And everything in between is what people get into with recreational dosing. And there's a spectrum of that from good to not so good. And we can talk about that in a minute. So, and the doses depends on, it's variable. It's quite different people, 20 milligrams in you might produce a nice hallucination, whereas other people freak right out, and it's very person dependent. So small doses, dancing, a bit higher doses, you hallucinate and perception changes. Even higher, you start losing grasp of reality. And we'll talk about the infamous K-hole in a minute. And higher still than you're unconscious. So the K-land or the recreational doses, you get a euphoria and well-being. You feel like you're floating and hovering. You feel connected to people. You're walking around. You're a bit stoned. You know that you're affected, but you're aware of your faculties. You're just having sort of a good time. And hallucinations, and they're usually good hallucinations when you get them. So the hallucinations that you get, nice colors, light going through your body. You lose sort of track of time. People get weird stuff about their hand, like look how big my hand is, or gee, I feel like I'm made of wood, that sort of stuff, So you got those things, and then you got the completely dissociated ones that have said that you're unconscious. And then between the K-land and complete dissociation is the infamous K-hole. Now, people say K-hole is when you dissociate. That's not strictly true. It's when you're partially dissociated. So I've put people in the K-hole. So when you go from the small doses to dissociated dose to do an anesthetic for a dislocated shoulder, for example, on the way in and on the way back out, there's the K-hole bit. You know what I mean? So it all depends on how fast you do it and the setting and all that sort of stuff about how good or bad that experience may be. So if you just go, you go bang straight in the K-hole and just, oh my God. Whereas if you just do it slowly and you word people up, it's okay. So the K-hole is a complete detachment from reality. It's a weird, it's really hard to explain. I think I've got a slide that says the only way to really know what ketamine feels like is to actually take ketamine. I guess it's like, pregnancy or riding a bike. You can explain it, but unless you do it, you don't know how it feels. So, and K-hole is enjoyable or quite frightening depending on where you're at. So, this guy is in the K-hole. I mean, I'm not sure whether he's having a good time or not a bad time. And when you're in there, you're aware, but you can't speak, you can't move, you can't do anything. And that could be intermittent, like you can respond, but sometimes you're just lying there, so you don't know what's going on. So this guy is not having a good time in the K-hole. I want to do ketamine with her, and I want to be that guy when I'm in ketamine. So it's all very variable. So they describe 6 main categories of K-hole. The most common one is this near-death experience, out-of-body experience feeling. But people, talk about having contact with aliens, and these are so real at the time, and depending on where you're at, will depend on whether you're enjoying that experience or not enjoying that experience. So you can have, you can enter information networks, have access to alternative realities, start having these crazy ideas about it, problem-solve stuff, and tantric sexual stuff, which I haven't got much experience with. The near-death experience stuff is usually an out-of-body thing where you're actually completely detached from your body. Actually, you can see yourself either next to you or you're floating above, looking at you, just going, that's me. And it's so real, going, oh my God, this is really weird. Some people like that. Some people just don't like that at all. Some people feel like they're convinced that they're dead. And that could be quite frightening if you don't want to be. tunnel stuff, like you're moving really, really fast in a tunnel, going from dark then to light, that sort of stuff. Noises, ringing, whooshing sounds, and telepathic communication with, higher beings like God and stuff. So it could be quite a full-on experience. That's what I was saying. You don't really know unless you take it. Not that I'm saying you should, but if you do it safely. So how do you take it? You can take it in lots of ways. The most common way probably is snorting it. And the people that I see, or when you speak to patients who come in for a different problem, so do you use drugs? Yeah. What do you use? Like ketamine? Oh, how do you do it? You sort of is bumps, and a bump is a dose, which is a small dose that you just snort, or you can snort lines. And that's usually in a party atmosphere or a club type of arrangement. But people inject. That's another common way of doing it. Different person. And then there's ingesting, drinking, and gumming. And I'm not really. And ingesting is you put the powder in something like, I don't know, a cigarette wrapper or something, and swallow it. So the onset is slower, the offset is slower, the intensity is less. I don't know how many people actually do that. Drinking it, I don't know why you drink it, but it tastes a bit bitter. So you put it in apple juice, an acidic thing, and then drink it, or gumming it, which is like putting it on your gums or your thing. I don't have any figures to know how people do that. Most people will probably snort it, I would think, and some people would inject it, and there'll be a mixture of everything else. I mean, the doses are not really that important. The snorting, I mean, to give you an example, I would give roughly 1 milligram per kilogram if I was to completely dissociate you to do a procedure. So a 100 kilo person, I'd give 100 milligrams intravenously, and that would be where I want them to be generally. So snorting is, they're the doses there, and again, how pure it is, how much you have, and the bumps, depending on how big your little scoopy thing is to snort, will depend on how many milligrams it is. So a bump might make you feel nice, but a bump might be a bit too big, and therefore you get a bit, not K-holey, right, but you just not a bit too much. From snorting, starts at about 5 to 15 minutes. The duration, I mean, that's quite variable, 45 to 90. And that duration, I mean, before it starts, not you're completely normal after 90 minutes, it just starts waning, getting out of your system after that. So you have the full-on experience for 45 to 90 minutes, and then you start sort of getting. So people, when they're at parties, they do a bump, and then a few hours later do another one, and then they have several throughout a night, perhaps, or not. And it can take about 1 to 3 hours for it to, the effects are sort of finished from the original experience. Basic stuff, the higher the dose, the more intense the effects, and the more intense the effects, the more likely you're going to experience negative effects. From a medical point of view, your pupils get bigger, your heart rate gets increases, your blood pressure increases, you can salivate, you can tear up, you have weird eye movements that are tracking, and some patients that I've dissociated for procedures talk about having blurry vision for about 20 minutes after they come out of the anaesthetic. You can stiffen up with your muscles, and nausea, vomiting is not common, but it's not uncommon either. So I tend to give people an antiemetic before I give them the anaesthetic. And then the come down is the usual stuff, it's not nice, aches and pains, a bit flat, a bit anxious. But you can also have problems with impaired judgment and memory loss. So that can last a day or so. So in terms of harm reduction, I think, I wouldn't drive a day after taking ketamine from a safety point of view. Yeah. Okay. Most people mix it with other drugs. It's not, they don't go out to do ketamine. Some people do, but most people that I see, or in recreational circles, they do other drugs, and ketamine is just taken along for the ride. And low risk mixing with other drugs, are all the drugs that just can make you hallucinate and make you feel nice, similar to ketamine, I guess. So you got, magic mushrooms and nitrous and ecstasy and acid. And the high risk ones, which are always the high risk ones with a lot of mixing with drugs, are all the things that make you sedated, like GHB, alcohol, benzos, and opioids. And if you're going to be, dissociated state because you've done too much and you're just lying there and you're vomiting and you're also sedated with other stuff, that's when the high risk stuff comes in. And you guys probably know about this, the chart of mixing drugs that gives you an idea of how safe or not safe it would be. I've just highlighted ketamine there. All the purple ones are, low risk, and they're the ones that I've just mentioned. And the red ones are the high risk, which is the ones that I mentioned. And the ones that you should take caution with are the stimulants like cocaine and methamphetamine, only because that they also increase your blood pressure and heart rate. And if you've got two drugs that do the same thing, it's probably not a good idea. This is just some data. So the green graph line is showing the use of ketamine over the last, few years in Australia, and it's increased in the last 5 or 6 years. And if you look at the state, so this is people who take ecstasy who've been surveyed to say, do you do ketamine as well? And in Victoria, 84% of people who take ecstasy have said that they've taken ketamine. So it's quite common for people to go out clubbing or parties, whatever, to take ecstasy and take ketamine as well. And Victoria are the champions of ketamine. Okay. And Melbourne, out of all the major cities, is the black line on the top. So we're the king. We're the king of ketamine. So deaths. Do people die? So my experience is from an emergency physician and a toxicologist. And to be honest, my experience with ketamine is when I've given people ketamine and when I've spoken to people who take drugs and come in for another reason, and I start asking them about their drug use and ketamine comes up, and then have a conversation about ketamine. But in actually seeing people come in with a ketamine problem is an unusual thing in the emergency department. So most people, if they have a problem with ketamine, it gets managed pre-hospitally, either at home with friends or at festivals with dance wise and harm reduction people. So, and in the literature, I think there's only ever been less than a handful of people, because it's really hard to separate. The coroner is saying that they're seeing more people dying now that have got ketamine in their system. They're not dying of ketamine, they just happen to have ketamine in their system. So it's rare for people to just take ketamine on its own, and it's rare to find out people that have just died from taking ketamine from the drug. If you do die from ketamine, it's usually because you've mixed it with other drugs, or it's a traumatic death. What traumatic death means? You're in a situation where you can't do anything because you've partially dissociated, and you're in a river or a lake, or you're outside and you become hypothermic, or you're driving your car and you have an accident, or sexual assault stuff. This is just a graph of drug deaths in Australia. The blue line are opioids, and they've always been number one. Opioids are the thing that kills most people. I've underlined ketamine there because it specifically says we don't have a graph for ketamine because the death rate is so low that there's not even point putting it on the graph. Just to highlight, I'm not saying ketamine's safe, go for it. I'm just saying, relatively speaking, in terms of high risk drug taking, opioids, benzos, and anything that will make you sedated and lose your airway and so forth are the ones that kill you. A guy called Turner wrote a book on psychedelic drugs. He was a psychedelic researcher, and he also researched on himself as well. So he used to take the drugs, so he was a psychonaut as well. So this book came out in 94, and in 96 he was in a spa, injected ketamine and drowned. So just to say that he probably didn't die from a ketamine overdose. He died from drowning because he took ketamine intravenously in the spa bathroom. Speaking to some Dancewise colleagues, they were saying that in the last 12 months at festivals that Dancewise have been at, they've treated 557 people, of which 161 of them was for ketamine, and it's probably going to be for partially dissociated people just lying there not moving, sort of being comforted and reassured. Number one substance, what do you reckon? Huh? Alcohol. It's always number one, isn't it? But it's legal, it's fine. It's all good, it's all fine. Okay, so when they come to the ED, which is unusual, this is my friend, they've taken ketamine, can you help them? That's an unusual presentation. It's just supportive care and reassurance, because it doesn't last that long in terms of that effect. Like I said, 45 to 90 minutes. So by the time you take ketamine, people realize that you're in the K-hole not having a good time or whatever else. And then by the time you get to hospital, by the time you see me, you haven't got that problem anymore. The problem that you have is managing all the other drugs that are on board, whether it's meth or MDMA or whatever it is. There's no antidote and there's no decontaminate, there's no charcoal, or there's nothing like that. There's just supportive care. Which comes to the chronic effects. And again, we don't get to see them much, probably because doctors are not very good at taking drug histories. I don't know why, but they're not. And people who might have chronic effects that we don't tend to know why, it could be because they've taken too much. And it's hard to know how much ketamine do you need to take for how long to get these effects. So you got psychiatric effects like low mood, being depressed, and sometimes even psychosis. Neurological, it can affect your higher functioning and memory. And that's been shown on MRIs that people have taken, like a gram a day for 2 or 3 years, which is, that's a lot of ketamine. It does change the way your brain functions and looks. Everyone knows about ketamine bladder, or the urological symptoms where you get sort of inflammation and cystitis of your bladder all the way to urethra and ureter. And that can be tricky to treat. Unless you stop it, it's not going to get treated. People get Botox. People have even had their bladders removed because it's so painful. So they present like they've got a UTI, but no bug's ever been grown. So they just get antibiotics until someone goes, oh, hold on, maybe it's the ketamine. Biliary stuff, the K cramps, people get abdominal, they get common bile duct dilatation, liver function test abnormalities. And addiction, it's probably psychological rather than physiological. It's not like benzos, opioids, and alcohol and GHB dependent stuff. It's more a psychological sort of dependent. And speaking to our local detox place in Curran Place near the Austin, I think they've detoxed one person from ketamine in the last 12 months. So it's either not happening or it's part of the whole broader drug group. I better keep moving. Drug tests, we don't, speaking of drug tests. So EDNAV, I don't know whether you guys know about EDNAV, Emerging Drugs Network Victoria. It's a project where we have funding to take blood samples of people who come into emergency departments all around Victoria. Not every hospital is involved, but most of them are, and analyze their blood. It's not a real-time thing. It's more of a toxicosurveillance thing, and pretty much the things that we see are GHB, methamphetamine, and illicit benzodiazepines are by far the most common things. But, we get lots of drugs. So ketamine, we have detected ketamine. So of the almost 1,200 samples in the last 12 months, 79 of them had ketamine in their blood. Most of them are just co-detected with all the other drugs that people take ketamine with. Only 4 of the 79 had no other illicit drug co-detections, but all those 4 had alcohol. So it just seems to me that if you take ketamine and land in hospital, you're landing in hospital because you've taken something else, not because of the ketamine per se. And through this project and knowing the drug samples, we've put out alerts through the health department that things like hydroxy PCP being sold as ketamine, which is more potent, longer lasting, takes a while to come on, so people redose and get into trouble. So we've had people get into trouble with that, which is another advertisement of, can we have some sort of drug testing facility here so people can be safe about using drugs. And more frightening for me, protonidazine is a novel opioid. So when you're taking ketamine and you're snorting it and then you stop breathing and then you die. We had 4 people come in a week. One of them died because they thought they were taking ketamine. That's not good. So that was another alert that came out. Harm reduction stuff, I don't need to tell you guys, you're probably all over it. Drug Foundation, DanceWise, TripSit, and Aerowid, Reduction Victoria, good websites to look at. The usual stuff, start low, don't use alone, avoid mixing drugs, have someone that's not doing ketamine sit with you so you can get you through it, driving advice. And I put naloxone there because I'm a believer that I think naloxone should just be everywhere. There's too many cases that I've seen that people have taken methamphetamine and it's not, and it's heroin, and they've dropped and they've stopped breathing and that sort of stuff. And just this week in Sydney, somebody snorted coke, but it was heroin, and they dropped and ended up in ICU. So, and people use drugs differently. I don't know. I'm not a cocaine user, but I'm sure people go to pubs or parties and just go to the bathroom and have a snort and come back out. They do it alone. If it was heroin, they just drop. No one's in there. So maybe, naloxone should be everywhere. Wherever there's a defibrillator, there should be naloxone or something like that, because it's life-saving. I've probably got no time for my notable cases, but we can talk about it in the break. I can tell you about my 100-year-old that I've given ketamine to, and the K-hole that I've put somebody in with tonsillitis, and the Mark Philippoussis story, which is funny. In terms of pricing, it's quite expensive in Australia compared to other countries. So therefore, I'm not sure why it's getting more popular now. Maybe the price has gone down, or whether it's inflation's gone up, but the price of ketamine has remained the same. So therefore, it's relatively cheap. But in the UK, it's about 20 quid for a gram. Here, it's about $200. So it's relatively expensive compared to Europe. And that's all I've got. So I was a bit rushed at the end. Thank you.
Thank you. Thank you very much, Zeff, for an enlightening presentation. We don't have a ton of time for questions, but I will grab kind of two quick ones. And then I believe you're going to be here for the break this afternoon.
Yes,
if
I
anyone
will be.
has questions
Yes,
for
I
you
will
as
be.
well.
Yep.
One of the big ones online is people wondering what the vampire logo is on your
Ah,
slides.
God, out of all that, that's what you got out of it.
That's the burning question.
We're part of a network with Monash Hospital. We've also got a toxicology service. So it's Victoria, Austin, Monash, Poisons Information Research and Education. And because we do most of our work after hours and at night, we're vampires. So.
One of my favorite acronyms yet. Thank you. We have time for one question from the audience, if anyone had one for Zeff?
I wanted to ask about if someone presenting. It's okay. I think. Oh, okay. Oh, sorry. You're saying there's no real treatment, just supportive care. But would you ever give them more ketamine if they were really frightened and really freaking out?
It's a good question. We tend to give more ketamine when we've given them ketamine and not enough ketamine. So therefore, we need to give them more ketamine because we haven't given them enough ketamine. We don't tend to give people who've come in with a ketamine problem more ketamine. Yeah, you can get agitated when you come out of stuff. So they do get some sedation with benzodiazepines, but not more ketamine. Yeah, it would be, but we don't tend to get too many of those presentations. We tend to get people who are unconscious with GHB, for example, and then they wake up and say, yeah, I took G and ketamine, I've done this and I've done that, but they weren't really K-holing, if you know what I mean.
Hi, I'm Baden. I regularly use ketamine. I was just wondering if you knew if when you give people ketamine,
yep.
If it drops their tolerance if they're regular opioid users?
If they're regular opioid users or regular ketamine users?
Regular opioid users, if it drops the tolerance to the opioids when you give
no. So it's sort of a different receptor group. So we tend to use ketamine for people who are opioid tolerant because we can't give them enough opioids to manage their pain, for example, because they're opioid tolerant, whereas give ketamine, you can get on top of it that way. But people who take, substances generally have a tolerance to lots of substances. So we find people who are big drinkers, for example, need more anesthetic for lots of reasons because, the liver chews it up quicker and all that sort of stuff. So people take substances usually tend to take more of the substances that I want to give them. But in terms of an opioid ketamine cross-reactivity, no.
Did you ask that because they were saying that activates the opioids?
Yeah, there was. It does, but not in any major way. Like I said, naloxone is not going to wake you up from it. It just. There are many opioid receptors, and they all modulate pain in a different way. Yeah.
Is that what you mean? Yeah.
What was that?
Well, because it
After the ketamine experience.
because it's already activated.
We don't see that many. I don't see too many people that inject heroin that I have to give ketamine to get a feel for. I should change those. Yeah. Yeah. Okay.
Very engaging discussions. I hate to cut it short,
Yeah.
but I do want to make sure that we give Manita her space.
Yeah,
for the
absolutely. Yeah.
Culture discussion. So I'm going to take a moment to thank Zeff for his presentation. And again, encourage you all to catch him on the breaks or this afternoon if you have any further things you wanted to discuss with him. So next up, I'm very happy to welcome Manita.